I think everyone should be able to see that now. But yeah, I'm going to be talking about my PhD project that looks at the adverse health effects of exposure to PM 2.5 on the London Underground. And I'm in my final year of my PhD, and I'm writing up my thesis at the moment. So I'm sure a lot of you are familiar with the London Underground. It's the world's oldest subway system, and it opened in 1863. So when it first opened, it looked kind of like the picture on the left. But nowadays, you're probably more familiar with the picture on the right. That's how it kind of looks most days. And it provides over 2.8 million journeys every day. And you might have seen that there's been a recent increase in interest across different forms of media about the poor air quality on the London Underground and the high levels of tube dust. You can see newspaper articles, but also across various forms of social media like TikTok and Twitter and so on. There has been a lot of videos that have gained a lot of interest. So the aim of my PhD was to look at whether exposure to PM on the LU is associated with any cardiorespiratory health effects. So the LU employs over 19,000 staff members every year. And based on previous studies, we know that the PM concentration on the LU can be over 15 times higher than what you see on a busy road in London. But because there are lots of differences in both the chemical and physical composition of LUPM, it's really hard to translate the health effects of traffic and outdoor pollution over to LUPM. So we were trying to look at cardiorespiratory health effects. And this study came about from a report that was conducted by the Committee on the Medical Effects of Air Pollutants that was done in 2019. And essentially, they couldn't come up with any conclusive evidence that stated particulate air pollution on the LU was linked to any health effects. So one of their recommendations, which the study was based on, was to look at ways to increase the usefulness of employment health records of those working on the underground to assess potential adverse health effects of underground exposures. So this is what we did, and we conducted 2 studies. So the first study is a retrospective cohort study that took place, that looked at the period from 2014 to 2019, and there were close to 30,000 members in this cohort. And the results of this study has been published if you're interested in finding out a little bit more. But the first thing we did was conduct measurement campaigns across the network to quantify occupational exposure. And we conducted both personal measurements as well as static measurements for drivers and customer service staff in different locations. We extracted data, sickness absence data, from the HR database of TfL, and we used mixed effect models to look at the sickness absence rates across the cohort. So as I mentioned, there were close to 30,000 members in this cohort, and over half of them were office-based staff, so people who are not occupationally exposed to LUPM. There was a big selection of customer service staff as well. So these are people working at the stations that you're most likely to encounter when you're taking the tube. And there are drivers as well, forming 14% of the cohort, and engineers forming the smallest proportion of the cohort. Now, this is a male-skewed cohort with close to 3/4 of the population being men. So if we move on now to some of the measurement results from the measurement campaigns we conducted, we sampled drivers across the different lines, and these were some of the results we found. And as you can see, even amongst the same role, a tube driver, there's a very wide level of heterogeneity across the population. So some patterns begin to emerge if you look closely at this. On the lower end of the spectrum, the District, Metropolitan, Circle, and Hammersmith and City line, they're shallow lines, and they mostly travel above ground. They also operate more modernized rolling stock, so the trains, which can, I guess, contributed to this lower concentration that you see. On the other hand, if you look at the Victoria, Bakerloo, and Piccadilly lines, these are trains that spend more time within the tunnels and underground, and they generally travel deeper as well. They also operate these older rolling stock, especially the Piccadilly line. When you think about a station within the tube as well, within the underground, you might think it's one environment, but actually upon closer inspection and observation, there's actually a few different microenvironments that begin to emerge. So this included the office, the ticket hall, the platform, and the confines. And as you can see, the concentrations of PM across these different microenvironments vary greatly. So depending on what job someone did and how much time they spent in these different microenvironments, that would greatly influence their daily occupational exposure. So someone who spends more time on the platforms would have a higher occupational exposure compared to someone who spends more time within the office. So again, this goes to highlight that even within one location, a station, it's quite a complex environment, and trying to understand people's exposure is really important to prevent bias in our health results. So if we now move on to some of the results from this first study, we looked at the associations between job groups as a proxy for exposure and sickness absence episodes. And we used office-based staff who are occupationally unexposed to LUPM as our reference group. The next group up was fleet engineers who work on maintaining the trains, but they work in depots that are separate to the network, so they have a fairly low occupational exposure. Then we move up onto the customer service staff within the stations, and our most exposed group is our drivers. So when we looked at all causes of sickness absence, all three of these job categories compared to our office-based staff had significantly higher rates of sickness absence, and that was seen as well within respiratory infections in particular. And we didn't find any significant evidence or associations for non-infectious respiratory sickness absences or cardiovascular sickness absences. But one thing we did was we then looked at doctor-certified sickness absence episodes for our non-infectious respiratory and cardiovascular sickness absences. And from here, we can then see that customer service and drivers had significantly higher rates of sickness absence for respiratory, non-infectious respiratory sickness absences, and the customer service staff had higher rates of cardiovascular sickness absences. We then took a bit of a more detailed look at the drivers, because one kind of limitation in the previous analysis we did was that when you're comparing across these different job groups, there are quite a lot of demographic differences, both in terms of age, makeup of the proportion of sex between the different job groups, as well as socioeconomic status. So we looked at drivers in particular that we thought would be a more kind of fair comparison. And luckily for us, the drivers on the London Underground only drive on one line because of differences in signaling patterns as well as the controls on the trains. So it made our job a lot easier when we were comparing these different drivers. So here we use the district line as our reference group, as they had the lowest concentration of PM. And these are going up in ascending order based on the measurements we took earlier in the study. And when we're looking at all causes of sickness absence, 5 out of the 8 groups had significantly higher rates of sickness absence compared to district line drivers. And for respiratory infections, only the central line drivers had higher rates of sickness absence. Again, we didn't see any evidence between non-infectious respiratory or cardiovascular sickness absences. And this perhaps was not what we hypothesized we'd see. We hypothesized we'd see a nice dose response relationship. So the higher concentration and higher exposure, the line, the higher rate of sickness absence, but this wasn't seen. So there are some limitations in this study. So as we saw, LUPM exposure is associated with sickness absence in some cases, but perhaps not enough for us to be able to say that there is a causal relationship. But one of the limitations is that there could be misreporting in sickness absence, both in terms of self-diagnosing their sickness absence cause, as well as perhaps managers misentering the sickness absence information onto the HR database where we extracted our data. So we did do the doctor-certified sickness absence as a sensitivity analysis, which was helpful, and we uncovered some more associations there. But there's also a lot of individual behavior that we couldn't account for within the study in terms of both the exposure side as well as the sickness absence side. So when we're talking about exposure, there is a lot of variation. So some of the drivers I spoke to enjoyed driving with their windows open or even their doors open, which would have significantly increased their exposure while they're going through the tunnels. Similarly, with the customer service staff, while they're mandated to do 1 hour of platform duty, standing on the platform and helping direct customers during their shift, some of them really enjoyed platform duty, so they'd switch with their colleagues and end up doing 3 or 4 hours there. So again, that would have increased their exposure. And in terms of the sickness absence behavior, there could perhaps be more presenteeism or absenteeism within individuals, as well as certain groups that would have been difficult to account for within our analysis. There is the healthy worker effect, so some of the results may not be representative of what we see in the population. And we only looked at cardiovascular and respiratory health outcomes, which is fairly limited as we now know that PM is associated with other health outcomes as well. So that then kind of brought us to our second study. And these are some articles and minute meetings that I uncovered when I was in the beginning of doing the second study. But these are articles and minutes from the 1970s, and it just goes to highlight that the issue and the concern around tube dust and health is not kind of a recent issue that was recently uncovered in the media, but the union workers as well as the general population were also concerned even back in the 70s. So it seemed to be a recurring issue. And in fact, some of the working conditions were significantly different to what we see today. So these are tube fluffers in the 1940s and 50s, and they're essentially people who would go into the tunnel when the train stopped operating at night to clean the tunnel with dustpans and little brushes. So it kind of emphasizes that their exposure would be significantly higher. But this is our second study, which again is a retrospective cohort study that looked at employees that worked at TfL between 1960 and 2010. So we had over 100,000 members in this cohort. The first step was to extract historical measurement data from the TfL archives, and then we extracted mortality data from the pension fund database. So based on who was still being paid out by the pension fund and who had stopped, that was how whether the vital status of someone was determined. And additionally, the pension fund would generally store death certificates. So when someone died, they'd have access to kind of when they died as well as the causes of death on the death certificate. And then we used Cox proportional hazards models to look at mortality. So this is our cohort, and again, a large proportion of this cohort was office-based staff. And then we had 22% LU staff, so London Underground staff, and 7% engineers. We also had 13% bus staff. So as you can see, this job categorization and stratification is slightly different to what we did in study one. And that's kind of a byproduct of the history and the age of this data. So there is a bit of difference, and there are some limitations in how this was grouped. So for example, you can see LU is a group in and of itself compared to our previous analysis where we could group staff into drivers as well as customer service staff. And we couldn't do that here because we didn't have access to people's exact job titles, and we only knew the organization in which they worked. So within our LU staff, LU group here, we have a combination of drivers, customer service staff, and perhaps some people that worked in the office as well. And you might have seen this bus group here that is no longer part of TfL. They became privatized in 1994, so there are some bus members here, but they're kind of a historical group as well. And as well as engineers, there are a really kind of a big variety of different engineers, including fleet and track staff, as well as civil engineers or architects who would have all fallen under this group. And I'm just mentioning this here because, as you might be able to tell, one of the limitations is that it wasn't easy to pinpoint everyone's exposure, especially historical exposure, and it was made even more difficult by the lack of kind of granularity in their job titles and job categories. But again, this is quite a male-skewed cohort, with 81% being men, and 67% of the cohort were still alive, and 32 were dead. So this is just some of the data that was extracted from the archives that looked at concentration of dust, historical concentration of dust. So this goes back to 1967, between 1967 and 1989. And what you can, one thing you should bear in mind when you're looking at this is that there is a difference in units. So this is milligrams per cubic meter, whereas the measurements we took are now in micrograms per cubic meter. So you can tell that the concentrations of dust have significantly come down since the 60s and 70s, but you can also see that there are system-wide changes throughout this period of samples where that have significantly decreased the concentrations of dust, such as introduction of speed restrictions and the brake blocks being upgraded. So if we look at the physical and chemical composition of the historical dust, it's actually very similar to what we see nowadays, with kind of 50% still being iron nowadays. So then we looked at causes of death. So what we did was we extracted Part 1A of these death certificates, and a lot of that had to be manually done because they were stored as PDF or microfiche. So it was kind of quite a long process that TfL helped us undertake as well. So now when we moved on to the kind of results of our analysis, what we looked at was what we did was we used the office workers who are occupationally unexposed as our reference groups again. We had bus drivers who are kind of exposed to a completely different type of PM. They're exposed to traffic PM. And then we had engineers as a group that kind of could have been exposed to LUPM, but also couldn't. They're a bit mixed. But then we had our London Underground group, who again could have been a bit mixed, but had a high likelihood that they were occupationally exposed to LUPM. So when we looked at all causes of mortality, we saw that bus drivers, bus workers, and LU employees had significantly higher hazard ratios compared to office workers. We didn't see that for engineers, but if you notice that the confidence intervals for both for the bus drivers and the LU workers overlap, so that's quite hard to tell. So it's hard to draw conclusions about whether the bus drivers and the LU workers, which of them had higher rates of mortality compared to office workers. And we saw similar patterns in the respiratory and cardiovascular deaths, where bus drivers and LU workers had significantly higher risks of death compared to office workers, and not significant associations for the engineers. But when we then moved on to cancer deaths, all three of the groups, the three different job categories, had significantly higher hazard ratios compared to office workers. So that brings us on to talk about some of the study limitations. So again, we saw that LUPM exposure is associated with increased mortality in some cases, but it was hard to be certain about whether there's a causal effect. And with this study, as we used kind of older data, there are more limitations. So the first one was that there are really inconsistent measurements in terms of the methods, what instruments were used, as well as where they were conducted. So some of them they changed locations of where they were conducted, and also some of them were conducted in stations that are no longer in use now. So it's really hard to kind of pinpoint historical exposure. There is a lot of missing data, and that especially pertains to causes of death across the different job categories. So for office workers, we had about 60% of office workers had missing causes of death. So we knew they were dead, we just didn't know what they died of. And this was different to some of the other job categories, such as engineers, where only 20% of them had missing causes of death. So when we were looking at the previous results, perhaps there is a bias in some of the cause-specific mortality analysis that we did. So it's important to take some of those with a pinch of salt. There is a lot of there are very many covariates that we didn't have access to, such as smoking status or socioeconomic status that would have influenced mortality risk. And generally, the data lacked granularity, especially in terms of the job title and job categorization that I previously mentioned. So this brings us on to some of the recommendations